Imagine this: a woman with hypothyroidism comes with having irregular periods. Why? It's not just thyroid, it's estrogen physiology being disrupted. Today, we will break down exactly how thyroid hormones affect estrogen. The thyroid hormones exert multiple direct and indirect effects on estrogen physiology. These effects are mediated through the action of thyroid hormone first on liver and second on the hypothalamic pituitary gonadal axis. On the liver, the thyroid hormone increases the hepatic synthesis of sex hormone binding globulins, and also by the action on the liver, the thyroid hormone modulates the metabolism of estrogen. And secondly, at the hypothalamic pituitary gonadal axis, by altering the GnRH, LH, pulsatile release, and prolactin secretion, the clinical effects differ in hyperthyroidism versus hypothyroidism. Let's discuss it individually. The first one is hepatic sex hormone binding globulins regulation by thyroid hormone. The thyroid hormone upregulates the sex hormone binding globulins gene expression in hepatocytes. As the result, in case of hyperthyroidism, there is 2 to 3-fold increase in sex hormone binding globulins levels. The increased sex hormone binding globulins result in more estrogen bound to sex hormone binding globulins, and paradoxically, total estrogen level increase and free estrogen, which is biologically active form, may remain normal or slightly low. And in case of hypothyroidism, there is decreased sex hormone binding globulins level, result in the less binding of estrogen to globulins. As the result, there is higher free estrogen fraction despite low total estrogen level. Now, the effect of thyroid hormone on estrogen metabolism. The thyroid hormone induces several cytochrome like cytochrome P450. It also accelerating the phase 1 hydroxylation and phase 2 conjugation of estrogen and result in increased metabolism of estrogen. That is, estrogen are made more water soluble for biliary and urinary excretion. So in hyperthyroidism, there is increased hepatic clearance of estrogen and result in increased urinary estriol and catechol estrogen metabolites. Despite faster clearance, the total estrogen, that is bound plus free, looks high on lab reports because in hyperthyroidism there is increased metabolism of estrogen, but simultaneously the thyroid hormones make the liver produce more sex hormone binding globulins. This extra sex globulins bind to a large part of estrogen. So total estrogen appear high on laboratory reports, but the symptoms don't align with higher estrogen levels. Hot flushes, vaginal dryness, low libido, osteopenia suggest free estrogen deficiency. So always consider free level before labeling as a hyperestrogenic state. So in hyperthyroidism, there is increased clearance of estrogen, and despite high clearance, there is increased total estrogen level because of increased production sex globulins, and free estrogen level may be normal or low. In hypothyroidism, there is decreased cytochrome activity resulting in sluggish estrogen clearance. As the result, there is increased level of free estrogen and prolonged exposure of endometrium to unopposed estrogen levels. Third is interaction with hypothalamic pituitary gonadal axis. In case of hypothyroidism, there is increased secretion of TRH because of low thyroid hormone levels, which increased the TSH and prolactin levels. And increased prolactin levels suppressed the GnRH, LH and FSH levels, resulting in anovulation and luteal phase defect. In case of hyperthyroidism, because of increase of sex hormone binding globulins, which cause low free sex hormone levels in the blood, which stimulate the hypothalamus and result in increased production of GnRH and ultimately increased production of LH and FSH. In hyperthyroidism, the pituitary is more sensitive to GnRH, so LH release can be exaggerated. As GnRH and LH always release in a pulsatile manner, that is, GnRH is not released regularly but in small pulses at regular interval, but in hyperthyroidism, normal pulsatile rhythm of GnRH and LH is disturbed, resulting erratic cycles, that is, irregular cycles. So in hypothyroidism, there is suppressed GnRH, LH and FSH levels, and in hyperthyroidism, there is increased level of GnRH, LH and FSH levels, but the normal pulsatile rhythm is lost, resulting in irregular cycles. So clinically, in hyperthyroidism, because of increased metabolism of estrogen, there is increased production of sex hormone binding globulins, which decreases the free estrogen level, despite having high total estrogen level. Also in hyperthyroidism, there is disturbed pulsatile release of GnRH and LH, which cause the irregular cycles. So result in oligomenorrhea and amenorrhea because of decrease of estrogen level and disturbed pituitary axis. There is increased risk of miscarriage, infertility because of low estrogen levels. And also the sex hormone binding globulins increase in case of thyrotoxicosis, which bind to testosterone more avidly than estradiol, so cause the relative estrogen predominance. As the result, there may be gynecomastia in case of males. And in case of hypothyroidism, there is decreased sex hormone binding globulins, result in increased free fraction of estrogen, despite having low total estradiol levels. Decreased estrogen clearance so also increase the estrogen levels, increased prolactin levels, which cause decreased GnRH, LH and FSH levels. So in hypothyroidism, because of prolonged exposure of endometrium to unopposed estrogen levels, contributing to menorrhagia and endometrial hyperplasia risk, which increases the risk of endometrial carcinoma, breast tenderness, and also increased risk of breast carcinoma. There is anovulatory cycles, infertility because of decreased GnRH, LH, and FSH levels, and there is galactorrhea because of hyperprolactinemia.